Without further ado, I'd like to introduce my friend and colleague, Dr. Ruth Lathi, and she is very interested in recurrent miscarriage. She did her medical school training at University of California at San Francisco, followed by residency at Baylor, and she did a fellowship in reproductive endocrinology and infertility at Stanford. Where she currently is an assistant professor in the Department of OBGYN. So Dr. Lathi will be talking about overcoming miscarriage.
Okay, well, I want to, first of all, thank Dr. Jacobson for the lovely invitation and introduction. Thank Dr. Jim Batterson, Executive Director of the Women's Health Department, for the invitation to speak here today about overcoming miscarriage. As I listened to our opening speaker talk about women's health issues, I think it's really interesting that there are certain things in medicine that are uniquely female, uniquely applying to women. Only women can go through a miscarriage, not men. And as I was reflecting on what she was saying, a lot of the women's health issues are very emotional too. They're very deep to our heart, that when somebody goes through a miscarriage, that it's more than just a medical event, that there is a complex reaction that we have to these events. And what I wanted to focus on in today's discussion is overcoming miscarriage. What do we do when we have a miscarriage? How do we regroup afterwards? And what are the key components to moving forward and having a successful pregnancy as soon as possible? Not particularly tech savvy, but I'll do my best. So the objectives of this afternoon's talk will just be a brief definition of miscarriage and a review of causes of miscarriage, because I think the first step to moving on is understanding what happened. There's a variety of risk factors that we'll briefly go through, and then we'll focus on ways to improve outcome for future pregnancies and address any questions that we have from the audience. There are a number of things that we'll hopefully address in the question-answer period. I could give an entire talk on what doesn't cause miscarriage as well, that there are as many, if not more, theories out there about things that cause miscarriage that are false, that we need to also try to dispel these myths. But for the interest of time, I'll talk about things that we do know, not necessarily spend the entire time dispelling a lot of myths. So what is a miscarriage? A miscarriage is the loss of a clinically recognized pregnancy before viability. And we date our pregnancies based on gestational age weeks, which are started from the last normal period. If the pregnancy loss occurs before 10 weeks gestation, it's considered an early miscarriage, and a late miscarriage is considered anything that happens beyond 10 weeks. Recurrent miscarriage is a series of miscarriages, two or more consecutive. Can you guys hear me? Two or more consecutive. You want me to talk louder? Wow. Mary, he asked me to talk louder. Okay. Recurrent miscarriage is a series of two or more consecutive miscarriages. How do we diagnose a miscarriage? How do you know if you're having a miscarriage? How is it discovered? Typically, a woman who's pregnant, she knows she's pregnant because she's missed her period, or she's done a blood or urine test to confirm that she's pregnant. And then, it's a waiting game. We wait and see wait for the baby to show up. And we do a lot of things in pregnancy to monitor the progress. But sometimes early on in a pregnancy, a woman will start to experience pain or cramping or bleeding when she's pregnant. And these could be signs of miscarriage, although not always. If a woman starts to have these symptoms, she'll present to her physician's office, hopefully, and get an assessment. And we can assess how advanced the pregnancy is with either an ultrasound, which can be performed in the office or in the hospital, as well as blood work, or looking at the pregnancy hormone levels. If, unfortunately, the pregnancy has already passed, we don't have evidence of the miscarriage, physical evidence of the miscarriage, we may just see the hormone levels dropping, and then we'll know that the pregnancy has resolved naturally. So what should a woman do if she's worried about miscarriage or if she's concerned? I advise anyone with these types of concerns to immediately seek medical attention. Most most women do have access to health care, though not all. Call your OBGYN doctor's office and ask them what to do. Not every woman needs immediate evaluation, but urgent or evaluation within a very short period of time is often indicated. So don't necessarily wait at home to see what's going to happen, or ignore the symptoms, because early on, if the pregnancy can be assessed, we can get more information and potentially intervene to help with the pregnancy outcomes. So get as much information as possible. There are a number of women who might be concerned about having an evaluation, that seeing a doctor or getting an ultrasound might induce a miscarriage, but in fact that's not true. So the information we obtain at the time of evaluation may help us understand what is going on and give us more information about the cause of the loss. Genetic testing of the miscarriage tissue is critical to understand if there was a concrete fetal chromosomal cause of the miscarriage, and we'll go into that a little bit more. In addition, if a miscarriage does occur, there may be infection or infarction. Infarction is a restriction of blood flow to the placenta that could be diagnosed if the tissue is analyzed by a trained pathologist. In addition, the importance to seeking medical care and attention during a threatened miscarriage is to prevent complications from the miscarriage. Some women can have very heavy bleeding or develop a secondary infection if the miscarriage goes, there are complications from the miscarriage. So a pregnant woman who is having a complication is at risk for, maybe we can't save the pregnancy, but there could be long-term health consequences if the woman does not seek care during the time of a miscarriage. The one thing that I hope to convey during this lecture today is that miscarriage is very, very common. Most studies will recognize that anywhere from 15 to 25% of clinically recognized pregnancies end in miscarriage. And if we were to do population studies of women of reproductive age, estimates will show that anywhere from 30 to 50% of women will have experienced or will in her lifetime experience at least one miscarriage. So that means, look to the right, look to the left. Most of you are sitting in sort of groups of 3. At least one of you has had a miscarriage. So if there were a group of women sitting, talking together, a group of peers, a group of friends, the likelihood is that that there's more than one woman in that group that's had a miscarriage. So women are not alone. They don't always share their stories of miscarriage with one another, but it's incredibly common. It's not something that there's something wrong with that woman that she's having a miscarriage when everybody else is having babies. It's so common, but it's just rarely shared amongst peers. So I would just encourage you all to be supportive and helpful to your friends, open if they come to you with concerns or questions, so that we can all help each other through some of these difficult times. Despite the commonality of miscarriage, it's rare that people have multiple miscarriages. Only about 5% of women who are trying to conceive or have a child will experience more than one miscarriage. So very common to have one, less common to have 2. And only 1 to 2% of women will experience 3 or more miscarriages. So 1 miscarriage is very common. 2 or 3 or more starts to become less common, and that's when we start to do a more thorough evaluation for causes of miscarriage. The most common cause of miscarriage is fetal chromosome problems. So chromosome errors can occur when the egg and the sperm connect at the time of fertilization. It's common that there could be an extra or a missing chromosome. The pregnancy may develop relatively normally for the first several weeks, at which time the fetus doesn't develop quite the way it should and eventually perishes because of lack of normal genetic material. But the hormones and the symptoms and everything else about the pregnancy may be completely normal. Numeric chromosomal abnormalities can come from either the egg or the sperm. However, they most commonly come from the egg, but not always. Rarely are there genetic rearrangements that put somebody at increased risk for multiple miscarriages or chromosome rearrangements, but it's important to identify those patients at highest risk. Genetic testing of a miscarriage is the only way to know for sure if the miscarriage is due to a chromosome imbalance or not. So I recommend testing, in case you didn't get that point. Let's just review the human genetics a little bit more. What we see is this is a normal karyotype. We have 23 pairs of chromosomes, and there's a number of reasons for this. If you have, it's sort of like we have a backup set that a lot of women, if you have a problem with a gene on your chromosome number 1 here, you have an extra set that often can make up the function. So only if you end up with a genetic defect of both of your genes do you typically end up with a severe symptom of a genetic disorder. So that's probably the reason why we have 2 sets of each. In addition, there's one chromosome comes from the father, one chromosome comes from the mother, so we have a combination of genetic material from 2 parents as well. So we have men and women, girls and boys, have the first 22 sets are exactly the same. You have to have the right amount of genetic material of each chromosome, and females have 2 X's, and males have an X and a Y. So the only thing genetically that differentiates males from females is this little Y chromosome here. I think my next slide shows a little bit more. It's a little bit blurry, but this is a 7th grade biology slide of how mitosis and meiosis occurs. Mitosis is when cells divide and copy themselves exactly. Meiosis is when an egg or a sperm, a gamete, is formed that it somehow creates an exact half of the chromosome component. So the chromosomes duplicate and then segregate into each. So this would be, if this was an egg, a somatic cell or the egg precursor that has a normal 2 copies of each chromosome. The chromosomes are duplicated. So this is similar to mitosis and meiosis. The chromosome pairs separate. So you have sort of the maternal and paternal component, or the grand maternal and grand paternal. So these are really not. These are from the same mother, for example. And then the second stage is when the 2 pairs separate, and so you get one copy of each chromosome in each gamete, sperm or egg, as you form. If this segregation is abnormal or aberrant, and say at this stage both chromosomes go to one side, even if they split again, you're going to have no chromosomes, no representation of this chromosome in 2, and then double representation of that same chromosome in another egg or sperm. So this is what you want, one copy from each egg or sperm, and this is what you don't want, a missing chromosome or a duplication. This is the most common mechanism for how we get trisomies in either live births or miscarriages. So you can have duplication or missing chromosomes, and they're present in some medical syndromes that you may be aware of. Things like Down syndrome is a duplication of the 21st, so it's an extra copy of 21 chromosome. It's not actually technically a duplication because the 2 chromosomes are not the same, it's just that they didn't divide the way they were supposed to. And then something like Turner syndrome is missing a chromosome. So either way, you can end up with having an unbalanced offspring. Numeric chromosomal errors account for 50 to 70% of miscarriages. And for better or for worse, the chance of having a chromosome error increases with maternal age. As we get older, the eggs and the separation mechanism isn't quite as healthy as it was when we were younger. Numeric chromosome abnormalities of all 24 chromosomes have been reported in miscarriages, so it's not just one chromosome that's the one that's responsible for miscarriages. It could be any of the 24 chromosomes. As a general rule, with a very few exceptions, the chromosome numeric abnormalities are universally lethal. About 90 to 95% of genetically abnormal embryos will perish or will arrest before viability. So there will be a few exceptions that sneak through, but even chromosome abnormalities that have been reported in live births are very commonly, or even more commonly, seen in miscarriages than in live births. As I mentioned before, the chromosome abnormalities typically come from the eggs, but could come from the eggs or sperm. The one good news is that these chromosome separation problems that occur are random, that it's not, that if you've had one pregnancy that's affected by a chromosome abnormality, that you're likely to continue to have those same problems over and over again. I don't like to use the term bad luck, but it is just a pure random error. The risk of recurrence is very low. Here's just a graph that many of us may have seen before, which looks at the miscarriage rate based on maternal age. And we see that young women, say younger than age 35, have a fairly low risk of miscarriage. That if they get pregnant, if they have a clinically recognized pregnancy, the miscarriage rate is in that sort of 15% or so range. As we get older into 35 to 39, the miscarriage rate goes up to almost 25%. 40 to 45, about a 50% miscarriage rate per pregnancy. And women who conceive after age 45 do have about a 90+% miscarriage rate. Almost all pregnancies that occur in this age group will end in miscarriage and can be linked to chromosome problems in the eggs. Aside from age, which is something that we have very little control over in our lives, we wish we could reverse time, but we're where we are now. There are some other risk factors that are worth thinking about in the setting of a miscarriage, particularly if the miscarriage is found to be genetically normal. So if we have a genetically abnormal miscarriage, the outcome of pregnancy loss is an expected and natural event. We don't expect a chromosomally abnormal pregnancy to continue on. So it doesn't make us wonder what else is going on. In the setting of repeat miscarriages or miscarriages that occur that are proven to be genetically normal, we start to look at other factors. Particularly, is there something wrong with the uterus? Is there a congenital or acquired defect of the uterus that might increase the risk of miscarriage or make implantation or normal implantation less likely? So we have to always think about that. There are several chronic health problems that are associated with miscarriage. So women with underlying medical problems should make sure that any underlying medical problem, particularly disorders such as diabetes, hypertension, thyroid disease, these conditions should be controlled to the best of our ability prior to conception. Again, the miscarriage may occur. Once the miscarriage is recognized, there's nothing we can do necessarily to go back and say, oh, if I just give a little more blood pressure medication or thyroid, can we resurrect the pregnancy? No, it has to be done prior to conception. So one of the really important jobs that we have in taking care of women who want to get pregnant or who have suffered a loss is to maintain their best health that they can prior to pregnancy. There are a number of endocrine or fertility problems that are associated with miscarriage. Medications, a recent study showed that chronic use of over-the-counter pain medications such as Advil or Motrin, things that people take for back pain or headaches, things like that, have been associated with an increased risk of miscarriage. And extremes of body weight are also risk factors that should be examined in women who are over the normal rate or under should be examined. And then if a parental chromosome abnormality is known, this is a risk factor that has to be taken into account. I want to stress the importance of preconception optimization of maternal health because I think that in most cases this is our best chance to have a healthy pregnancy. Be healthy before you get pregnant. Examine other risk factors and optimize and reduce them as much as possible. Only in the setting of recurrent pregnancy loss do we start to embark on this evaluation for, there's a panel of tests that we look at, but after a single miscarriage, this is not necessary. If a miscarriage occurs, it's important to get clearance or an examination by an OBGYN prior to the next pregnancy to make sure that the hormone levels have come back to normal, that the uterus has passed the tissue or appears healthy, because clinical symptoms are not always reliable. We've often seen retained miscarriage tissue in women who have no symptoms whatsoever of it. So to give yourself the best chance moving forward, getting a good interval examination after the miscarriage before your next pregnancy may identify problems that can get in your way moving forward. I want to stress that recurrence rates are low. Women after having a single miscarriage have a very low chance of having another miscarriage. It does depend a little bit on maternal age, so we can't do better than our age-matched controls, but after a single miscarriage, the chance that the next pregnancy would end in miscarriage is not significantly different than someone who's never had a miscarriage before. But as I mentioned, it does depend a little bit on maternal age, and in the setting of repeat miscarriage, the number of prior miscarriages. The take-home message, though, is that live birth rates are high for all patients. That if you can get pregnant, you have a good chance of having a successful pregnancy if you just follow some of the basic guidelines I mentioned. I don't know how many more slides I have. I want to talk a little bit about moving forward since we're getting short on time. I do think that it is important to understand the cause of the loss, because knowing a prognosis can be very helpful in women who are pulling themselves together and trying to consider trying again. There's no substitute for taking care of yourself physically and emotionally. We see that, as I mentioned at the beginning, that the emotional reaction may be even stronger and longer lasting than the physical reaction to a miscarriage. That miscarriages tend to resolve without medical complications, but the incidence of depression after a single miscarriage is roughly 20%, and the incidence of depression after more than one miscarriage, 2 or more, is over 30%. So about 1 in 3 women who've had 2 or more miscarriages will experience a clinically significant depression, which is treatable. So these are things to take into account as we see patients or as we see our friends go through it. Depression is actually something that we should consider as a normal reaction to a miscarriage, and it can be treated, and it can be, and women can recover quickly from those. I tend to not recommend delaying the next attempt beyond 1 to 2 months after a miscarriage if it's uncomplicated, because I don't see any benefit in delaying the next attempt if someone's physically and emotionally ready. And just to stress and recognize the emotional impact of the miscarriage. I mentioned this already. We have just 1 minute left, so I'll go to my final slide here. I think this is the final. Don't give up. Women who've had a miscarriage may feel devastated by the experience. I see women in my practice all the time who've had multiple miscarriages, and that's not the topic we're here to discuss today. But it's very easy to feel the pain of a miscarriage and not want to go through it again. But with proper support, women can do very well and have successes. Those with a poor prognosis, if identified with significant underlying problems, have many options: assisted reproduction, pre-implantation genetics testing, oocyte donation, gestational carrier, and adoption. So there's not a single patient who's had any single explanation or number of miscarriages that can't begin her own family. So I just want to take a break now to answer any questions that we have and try to keep the forum on schedule for today. So thank you for your attention.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.